We can wait for 5 minutes.
So how the ESOC's going on, Dilip? You're on mute. You're on mute. You're on mute, Dilip.
I was saying that ESOC is really giving ISC a run for money. They announced like 6 big trials first day itself, right
Oh,
off the
great.
bat, and there are at least 12 or 14 more trials being announced. Like they're really becoming very important, and almost 4,000 plus attendees, or 4,000. There are 4,000 plus attendees. Very impressed.
Great, great, great.
Yeah, yeah. I saw Apratim Chatterjee from.
Okay, you met him today. Yeah.
Yeah,
I was
yeah.
supposed to come, but not able to make it this time. So
Right, right, right. No, no, no. It's definitely becomes a lot of conferences.
yeah.
I think Surya sir will introduce Dr. Dilip, no? Biodata.
Usha. I think short biodata is there with Dr. Surya.
So we wait for 2 more minutes and then start.
It was looking like that it going to be ESOC going to be like this only this time. The way the last time the ISC has presented, but the Chinese present a lot of trials in ISC.
Right,
Yeah,
right,
they don't come to ESOC much.
right.
One more minute. All right. Good evening, ladies and gentlemen. On behalf of Indian Stroke Association, I welcome you all for the webinar on the occasion of World Stroke Thrombectomy Day. ISA proudly announced the mission Brain Attack, none other than a place, holy place of Ganges from Kashi on Sunday. And we plan to have a total care in stroke. That means early prevention to the acute management, which will include the intravenous thrombolysis as well as the thrombectomy and the rehabilitation. Today, to mark on the occasion of World Thrombectomy Day, we have the man who has taken the mission not only in USA but across the globe to promote the thrombectomy is Dr. Dilip Yavgal from Miami. He will formally be introduced by the chairperson, Dr. Pradeep Kumar. But what is important thing is that stroke not been recognized as well as the heart attack. And therefore, ISA feel that we need to promote it as a brain attack. People must realize that it is the circulation in the brain which is getting affected, and therefore a person is paralyzed or disabled. And as you all know that there may be 1/3 of the people who can be left with severe disability and 1/3 with the moderate or to mild disability. And therefore, it is very, very important that we need to start from prevention, early diagnosis to early treatment and rehabilitation. So with that note, I welcome you all, and I'm sure you will be very excited with the new researches which are going on. And the Dilip Yavgal is the man today in the world. And not to forget our panelists' own Vikram Hude, the past treasurer of Indian Stroke Association, our EC member Trilochan and Sripal Shah, who all are actively involved into the thrombectomy as well as other action for the intra-arterial or in the brain action, what is required. So I won't take much of your time because we all are excited to hear. I hand over the stage to our past president, Dr. V.G. Pradeep Kumar, and Arvind Sharma, the secretary of Indian Stroke Association, to take this forward, a very interactive session, which will be, I'm sure, useful to all of you and to me. Thank you very much. Namaste.
Thank you, sir. Thank you, respected President of Indian Stroke Association, Dr. Nirmal Surya, sir, Secretary, Dr. Arvind Sharma, and the speaker of today, Dr. Dilip Yavgal, and the panelists. The first time in the history of Indian Stroke Association, we are observing World Stroke Thrombectomy Day. It's one of the important under the leadership and the able guidance and leadership of Dr. Nirmal Surya, who has taken charge as the President of Indian Stroke Association only a month ago. Under his leadership, there is a lot of programs have been envisaged to spread the message across the country, as he has mentioned that brain attack is just like heart attack, probably much worse than that. And we have to prevent brain attack. And if at all the brain attack occurs, we have to recognize it early and we have to take the treatment, provide the treatment to the patient at the correct time, in the correct way. So I think as a part of his mission, he has started the mission in Varanasi last weekend. And now this is another program, which is very soon coming up, the World Stroke Thrombectomy Day, which has never been observed by ISA before. And I congratulate the President and Secretary for this initiative. Today, we have a very, very valuable and guest speaker, Dr. Dilip R. Yavgal. He is not a guest, he is our own person. He is working as Miami, University of Miami School of Medicine. And he is a professor of clinical neurology and neurosurgery. And he is a director of interventional neurology, co-director of endovascular neurosurgery, director neurological stem cell platform, interdisciplinary stem cell institute. And he is also working with Jackson Memorial and University of Miami hospitals. He has initiated a program called Mission Thrombectomy across the globe. And India is, there is various subunits in India like North Zone, Subzone, West Zone, East, as well as in Central Zone. There are various zones which he is coordinating. And he is he's a very learned person. He has got extensive knowledge about the endovascular interventions in stroke as well as in other neurological diseases. And he will be speaking to us on the Mission Thrombectomy, the perspective of Indian perspective, present scenario, how it was formed, the present scenario, and the future perspective. And once again, I congratulate the office bearers of Indian Stroke Association, President Dr. Nirmal Surya sir and Dr. Arvind Sharma for this initiative. And with this introduction, I request Dr. Dilip Yavagal proceed with his presentation. Thank you. Jai Hind.
Thank you so much, Dr. Pradeep Kumar, for that very kind introduction. Jai Hind, and I really want to thank ISA, Dr. Surya, Dr. Arvind Sharma, and all of you for inviting me to participate in the India World Stroke Thrombectomy Day 2024 webinar. This is really very close to my heart, having been born in India and having gone to medical school and residency in India before coming to the US. India is never far from my thoughts, and the progress that Indian Stroke Association and all the neurology community in India has made for stroke care is something that is amazing to see. So I really appreciate this opportunity to share some thoughts with you on World Stroke Thrombectomy Day. If I may, I'll share my screen and just show a few slides. My goal is to maybe talk for about 10 minutes or so, and then we can have a panel discussion. So I will share my screen now. All right. All right. Please let me know if you can.
It's visible, and but yeah, it's full screen now. Please go ahead.
So these are my disclosures. I do consult for stroke device companies, but I don't have any royalties, or I don't have ownership in any of the companies. And what I'd like to do is really take this occasion to discuss why we should all be thinking about access to thrombectomy in India. And this is something that is the central goal of Mission Thrombectomy, is to rapidly increase access to this emergency procedure that is one of the most beneficial procedures, not only in stroke, but in all of medicine. And we'll talk about that. And it is highly cost effective. And that is why on World Stroke Thrombectomy Day, we bring focus to the need for this procedure to be available to each and every stroke patient in India and world over. So May 15th was declared as World Stroke Thrombectomy Day, actually with all of the Indian Mission Thrombectomy leaders in 2021, and we are observing the 4th World Stroke Thrombectomy Day today. Why bother about stroke? Why bother about thrombectomy? Because 1 in 4 of us, unfortunately, will have a stroke in our lifetime. And this grim statistic is not very well known. And so in my humble opinion, it is a pandemic that has been neglected for a long, long time, mainly because we didn't have much to offer to patients, and therefore it was ignored. But if you look at the statistics, stroke is the second leading cause of death in the world, and there are 13 million strokes per year, and out of those, over 2 million occur in India. And stroke leads to 5.2 million stroke deaths in 1 year, and leads to 116 million healthy years of life lost. Because as Dr. Surya said, there is a devastating effect of stroke causing paralysis, which disables patients. The statistic that's most relevant to our discussion today is that the disproportionate burden of stroke is borne by countries like India. 80% of all total disability adjusted life years are in developing countries. And 75% of all stroke deaths are in low and middle income countries. And I will ask my stroke expert colleagues who are here today about other India-related statistics that they are much more familiar with. But if one were to count the burden that India carries in the globe of stroke, it is a very heavy burden. For the first, so if you compare it with the pandemic that just got over, COVID caused 6 million deaths over 2 years, and yet it received far more attention than a stroke that causes over 5 million deaths a year. And this is why this neglect, this ignorance has to be overcome by observing and discussing on World Thrombectomy Day what can be done to overcome stroke. The good news is that we finally have an extremely effective tool in overcoming and fighting the disability that stroke causes. A procedure called thrombectomy, which I'll show you in a second, was proven to be highly effective in 6 landmark trials. 5 of them are here, where patients who received this emergency procedure had a significantly higher chance of being completely independent at 3 months as compared to medical treatment, which is in blue. And this led to the treatment becoming standard of care in 2015 across the globe. There was a recent study from Brazil called Resilient, which showed that this treatment, this procedure can be not only done, but is as effective as in high-income countries, even in a low and middle-income country like Brazil. And what's really also important to know is that even in Brazil, even in the Resilient trial, the procedure was highly cost-effective. And we'll talk about that in a second. But let me show you a case that illustrates this procedure. This is a patient of mine who came to Jackson Memorial Hospital with a 63-year-old woman who had discontinued her Coumadin, which she was on for AFib due to gynecological bleeding. She developed what is called a right MCA syndrome. And for those of the audience who are not neurologists, this is a sudden paralysis of the body on the left side. And their stroke score on a scale of 0 to 42 was 8. The CAT scan was done. There was no bleeding. And that means that very likely blood flow to this side of the brain, this is the right side of the brain, is cut off. And that's why the patient is paralyzed on the left side. This was very clear. Please ignore this arrow. It's misplaced. But this was very clear that there was indeed a cutoff of blood flow because we saw the clot right here at the end of the middle cerebral artery. When I took the patient to the angio suite to do the thrombectomy, this is a catheter procedure that's done in the angiography suite. Like the cardiologists do in the heart, we do this for the brain under advanced X-ray guidance. And what you can see is this artery called the carotid artery goes up into the brain, and it has 2 big branches, and this branch just stops right here, and the branches are not filling in the middle cerebral artery. And this is seen on the lateral view as all these branches being missing. And so this part of the brain is heavily suffering what is called ischemia and is about to die if this blood flow is not restored. The patient is at 2 hours, well within the window of treatment, which is now up to 24 hours. I took a micro catheter, you can see, across the blockage. And at this point, a thrombectomy was done where I took up a device called a stent retriever through the microcatheter. So this is how a catheter is taken up. The clot is crossed. And once the clot is crossed, this allows us to bring up a small catheter over the wire. And that catheter then allows us to bring the thrombectomy device to grab a hold of the clot. I'm going to speed this up a little bit to so that's where we are bringing the stent into the clot. It is called a stent retriever. This clot is now getting engaged and incorporated on the outer side of the stent. And then after waiting about 5 minutes, we pull out the stent and the clot together to unblock this blocked artery. And what you are able to achieve is a restoration of blood flow. So you see the clot is being brought out and removed from the artery and then from the body. And we restore the blood flow in the brain. And you can see this is the clot that was brought out. And we had complete what we call reperfusion of that area of brain that was suffering from lack of glucose and oxygen, lack of blood flow. This was done in 2014, so a long time back. I like to show this case because it was one of our first cases with a stent retriever, and it cut the time of the procedure into half. It used to take us around 2 hours with the older devices. This took only 52 minutes. And now my colleagues in India will tell you they do it and we do it in half the time of this time, so in 30 minutes or less. You can see the artery that was blocked is now open. The stroke that that evolved was very small. The stroke could have been occupying this entire right MCA territory, and that brain was saved. And this patient really went from being paralyzed on the left side to complete recovery and was discharged to home in 2 days without any deficits. And this was seen in over a total of close to 1,200 patients in these studies, that patients who got thrombectomy had this kind of independent outcome. And the safety was very, very high. Only 6% bleeding at the highest in the brain. And in some of the trials, it was as low as 1%. But the benefit was clearly very, very high, and the risk was really minimal for the benefit that was obtained. So you can see in this chart that if you only gave clot busting medication, you get about 13 patients to be to have some improvement, and only 2 are independent. Whereas with thrombectomy, the number of independent patients are 30 out of 100. And more than 54 patients here out of 30 have improvement with thrombectomy. So this was a major advance that allowed us to finally reverse severe stroke in stroke patients, which was really not possible prior to 2015 in a significant number of patients. And that led to the community recognizing the importance of acute stroke care, and the 4 pillars that have been declared by the World Health Organization include acute care as one of the main pillars, of course, apart from surveillance, prevention, and rehabilitation. So what I'd like to quickly show you in this video is a story of a neurologist. This is a neurology resident who unfortunately had a stroke when she was a medical student in Germany. And I'm not going to play the whole video, but I think it'll illustrate why each and every patient should receive thrombectomy if they are eligible, because it's really a difference between life and death, and being disabled versus being able to go to finish medical school and become a neurologist in this case.
Pain that came in waves and all parts of my face, and I realized at this point that I also couldn't call for help anymore because I couldn't talk. And luckily, my blood pressure went down though, and there was some alarm. And the neurologist that kind of realized had an upbeat and start was that kind of, I think, speeded up things a lot. And Well, I mean, I guess I was.
So just because of the accent and because video is not professional video, this is a good friend of mine now, Dr. Anna Bonkoff, who was a medical student in Germany when she developed a basilar occlusion and became actually locked in eventually. And she's saying that she was taken to the stroke center in Germany very quickly, and then she actually deteriorated once she was in the ER. And she'll tell you next is that luckily the interventionalist this was a Sunday, and the interventionalist was in the hospital for another case, and they did a thrombectomy right away on her.
Again, lucky to be. So this happened in a very densely populated area in Germany, and I was brought to a comprehensive stroke care center in Recklinghausen. That's the name of the city in Germany. And they had the neurointerventionalist there for another case. It was Sunday afternoon. So I was basically lucky that everything was very much streamlined. And well, whenever I was in the situation of being able to move or talk or, well, actually also see, because everything was just, I could receive this thrombectomy, I guess, as smoothly and quickly as it was possible. Could do everything again. So I could move, I could talk, I was actually like basically excited because it's difficult to put into words, but it was incredible to go from pretty much not being able to do anything and not knowing what the outcome could be, and then going back to basically just how I was doing before. But ever since, it just feels very, very special. And I think a lot of time has passed, and
what that story illustrates is that the benefit of thrombectomy is really unlike anything that we have for stroke treatment, and it can really be life-changing. From being paralyzed, she couldn't move any of her forelimbs because this was a basilar occlusion in the back of the brain. The artery was blocked, and she basically recovered completely immediately after the procedure, and is now doing her neurology residency at Mass General Hospital and Brigham Hospital in Boston, which is luckily where I trained. And this is the progress that is not only highly effective, and while it's costly, it's highly cost effective. Why is that? This study from Saudi Arabia shows that there was a saving of $600 million over 15 years if thrombectomy and other modern treatments were implemented. This is a simulation study. The cost of the procedure upfront is far outweighed by the savings of not having to care for a disabled person for 10, 20, 30 years, even longer if it's a younger patient. And that is the main reason that this treatment needs to be made available to every patient, rich or poor, living in a village or a city, because if they have a stroke, they are going to be devastated, either die, but even worse, they're going to be disabled and lying in a corner for the rest of their lives. And this completely gives them a more than 50% chance of independent recovery. This procedure has been studied for cost effectiveness across clinical trials, and in every healthcare system, public or private, it is cost effective, and it's been shown to be, like I showed you, cost-effective in high and low-income countries. Mission Thrombectomy was founded in 2016 to make this treatment widely available, but recognizing that this is going to take a lot of efforts from a lot of us, because new treatments can take 30, 40 years if not proactively introduced and proactively made accessible to really become available to the general population. We found from Mission Thrombectomy that the global access to stroke in the empty glass study, study of 61 countries, including India, as of 2020 was only 2.79%. Less than 3% access to thrombectomy is a highly dismal figure. And a brain-saving, life-saving therapy being available to less than 3% of the world population is something we have to change very quickly. And the disparity in access is also really very sad. Australia has 46% access. US has about 31% access. And the lowest access country is Bangladesh in this study, 0.1% access only. And India has about 0.48% access. And this is where I think things need to change very quickly so that we can get all the patients who are, India is right here. I'm sorry, it is 1.8% access. And so this is where we need to change the scenario in a big way. And the main two things that are clearly needed are a center that does thrombectomy and operators. And again, you can see the high-income countries have almost 180% access in Japan, whereas low-income countries have only about 2.75% access in Bangladesh and only about 10% empty center availability in India and 2.75% in Bangladesh. Number of operator availability is only 6% in India. And so this needs to change, but it is changing. And India is making good progress. As of 2019, about 2,000 procedures were done. And my friends here will correct me, but over 10,000 procedures, thrombectomies may have been done as of last year. The number of operators and centers are also going up, which is in India, which is really terrific. And the main steps that have been suggested by Indian experts is schemes to lower the cost of the procedure, to implement national guidelines, to increase healthcare awareness, health practitioner awareness of large vessel occlusion stroke, which is a stroke that thrombectomy treats, and thrombectomy itself. So I'm going to end here because of time, but I just wanted to show that Dr. Vinu Paul released the white paper that Mission Thrombectomy wrote, and many of you were part of it, the panelists. And this has had a terrific effect in awareness and in increasing reimbursement. And we have been very fortunate to have a very strong collaboration with Mission Thrombectomy India. I was just there a couple of months ago in Kolkata, meeting with everyone and conducting a workshop. And the awareness work in India has been terrific. The 5 regional committees have done tremendous groundwork. A BFAST dance challenge was launched 2 years ago, and the best dance challenge was done by India, where a Bharatnatyam dance performer brought out the signs and symptoms of stroke, which I'll show, and then we'll finish here and start the moderation of the panel discussion. Sorry, I wanted to show the BFAST. All right. So we are going to finish here, but New York Times covered the efforts of Mission Thrombectomy last year extensively, and the Core Executive Committee from India and the Mission Thrombectomy India Committee have been extremely hard at work to raise awareness, and I acknowledge all of your efforts, and thank you for calling me. I have to thank all the funders of Mission Thrombectomy, which are many of the device companies, and my university and hospital that have allowed me to work with all of you for Mission Thrombectomy. Thank you so much.
Thank you, Dr. Dilip Devagal, for that wonderful perspective of Mission Thrombectomy across the globe, and as pertaining especially how the importance of how to take it forward, improve awareness even amongst healthcare professionals, then cost of the treatment and the accessibility. Thank you for, and I want you to take questions from the panel and take this discussion forward.
Thank you. Great. So I'm very honored to moderate this panel of experts. Let me introduce the panelists, and perhaps so that I don't make a mistake, you can just say which hospital you're working at.
Dr. Dilip, we'll ask them to give their introduction. I think the three panelists are Dr. Vikram Hudaid, Dr. Shripal, and Dr. Trilochan. Dr. Vikram?
Yeah, hi Dilip. Hi everyone. I'm Vikram Hudaid. I'm an intervention neurologist in Narayana Health, Bangalore.
Shripal?
Good evening, everyone. Good evening, sir. Sir, I am Dr. Shripal Shah. I am an intervention neurologist at Sahyadri Super Speciality Hospital, Nasik, Maharashtra.
Good evening. I am Dr. Trilochan Srivastava. I am a senior professor at SMS Medical College, one of the largest medical college, government medical college in North India. And I think we have to make a good impact on thrombectomies. Yeah.
So Dr. Trilochan and Dr. Shripal are also our executive member for the Indian Stroke Association. And Dr. Vikram is our past treasurer for an EC member for Indian Stroke Association. Dr. Dilip, all yours.
Thank you so much. Again, it's an honor to moderate this panel. And I'd like to really have a free-flowing discussion about the ground realities of thrombectomy access from all of your expert perspectives. So the first question I would like to pose, and any of you can answer this, is am I correct in what you see in your practice? Is the data correct that the number of thrombectomies in India has been clearly increasing over the last 3 to 4 years?
Yes, sir.
Yeah, definitely. If you see at our institute, I think previously the thrombectomies are done in once in a month. Then last 2-3 years, it was a 2 or 3 thrombectomy in a month, and now one thrombectomy in a week. So definitely things are progressing, but yes, it's still slow, and we need to improve that data.
Dr. Shah, you were
yeah. Sir, I am in a 3-tier city. Previously, we used to do one thrombectomy in 3 to 4 months, or at least once in directly 6 months. That was the case. And now, as every year there are newer trials, change in the time window, plus awareness is very good. So now at least one thrombectomy I am doing per month, sir. So that has definitely changed, sir.
Awesome. Vikram, what do you think?
Overall, I think in India, with the numbers and more interventions and more centers, definitely the numbers have doubled or tripled. I think unless we do proper survey, I think according to the industry and in India, a lot of devices we reuse. I think numbers have doubled or tripled.
That's great to hear. So just to put this in perspective, the numbers that we have calculated roughly, not in a very precise manner, but actually in the empty glass study, we use the global burden of disease data to say that 10% of all ischemic strokes conservatively are what we call large vessel occlusion strokes, which can benefit from thrombectomy. And so for India, that number, if you took about 1.8 million strokes a year, and I know I'm using million, forgive me, but like 18 lakhs, right? 18 lakhs strokes a year. 10% would be about 1.8, or just to round it off, 2 lakh large vessel occlusions. And so if about 10,000 thrombectomies are being done as of last year, the gap is massive. And this seems very hard to bridge, but I think with all the efforts that you all are doing and Indian Stroke Association is doing, this could really be improved. So what I'd like to talk about next is the barriers and what you, in your opinion, is the most or the top 3 or 4 things that can really close this gap. So when a patient is brought to you, your center, Dr. Srivastav, how many hospitals have they typically gone before they come to you?
Usually 1 or 2 hospitals. So sometimes, yes, they waste maybe 2 or 3 hours before coming to us. And yes, if they come, sometimes they come directly to us. But yes, sometimes they go to one hospital or another hospital before they know that yes, thrombectomy facilities are not available. Luckily, in my city, there's at least 10 centers who do thrombectomies. So where if they go there, definitely the patient is entertained. But yes, there are some small centers where the thrombectomy facilities are not available, and then they have to come and they have to waste the time.
And does this lead to a number of patients falling outside the treatment window?
Yeah, exactly. Yeah, because 6 hours are really, because they go to one hospital and another hospital, definitely they lost the most important window of 6 hours, and they come in the late window. And late window thrombectomies, yes, prognosis not so good as in the early window thrombectomies. So that is the one of the challenges.
So in your opinion, the 3 panelists and the 3 panelists, what could be one of the big steps or the most impactful step to overcome this delay in going from hospital to hospital before coming to a thrombectomy center?
Yeah, because I think physicians, most of the physicians are not even aware of the thrombectomies. And even I'm working in medical college, sometimes our residents are not aware, even our consultants are not aware of this thrombectomy, that it is being done and it is one of the very good treatment. So beyond the public awareness, I think physician awareness is very, very important, because sometimes they go to the physicians and even the physicians don't know about the thrombectomies, and they don't refer the patient in proper time. So I think the education of physician is very, very, and resident doctors are very, very important. Otherwise, the time is delayed.
Vikram and Shripal?
Yeah, I think as told by Dr. Vilochan sir, along with that, I think the best way is to create awareness among general public. So whenever we create awareness among general public, I think they should demand thrombolysis, they should demand thrombectomy. I think after a lot of activities in Bangalore, now people are aware that there is some injection which can be given. There is a clot. Unless they demand, I think it is important to create awareness among physicians. But I think the people who are affected are the patients. I think once they demand or relatives demand, I think that's the only way where the numbers will increase, where the centers will increase, and where the government will also provide the service.
I agree. I agree. Go ahead, Dr. Shah.
Secondly, patients are not aware of advanced stroke centers or a stroke ready center. Once they get, they are not able to make out the signs and symptoms of stroke. Secondly, they are going to a nursing home or a doctor who tries to find out if it is a stroke or not. Then they will go to a MRI or a CT scan center. Then they go to a physician. So this takes long time of delay, sir. So directly they have to reach a center where everything is available and a person is available who is going to treat them holistically immediately, sir, and try to do the thrombectomy. So we have to highlight those centers also as per availability and the people who are doing. So at least they would be aware of that immediately treatment can be offered to them.
Do you think that similar to other health campaigns in India, and I was there, as I mentioned, for a long time, we could aim for a national stroke awareness campaign? Because until I went to medical school, really, I had no idea about what a stroke is, because stroke doesn't even indicate brain. The word doesn't even indicate brain. And so certainly in Hindi, we say lakwa, and that's well recognized. But what's your feeling about the possibility of a national stroke campaign being able to have an impact, stroke awareness campaign?
Yeah, stroke awareness campaign is very, very important. We do celebrate the program on Stroke Day, and that is the only day where we celebrate the program. But yes, I think it should be continuous program, and maybe every month we have to celebrate this one of the day with various groups, with the mainly with the populations, and mainly with the school childrens also, as well as with college going students. So I think. We have to be more aggressive in education, and I think every month we have to do some program rather than only on the World Stroke Day. So and I think we should involve the student from the school, from the colleges, and other public peoples also.
Yeah, especially because um, it's so reversible now. All of us see the kind of stories that I showed on the presentation of the German neurologist, and I think if the health ministry really realizes the power of spreading the word, and spreading the word that stroke is now treatable, it could make a big difference for a lot of people who would otherwise be paralyzed or dead. So that's really great. The second question I have for you is, once the patients do come to your center, there are still some major barriers, right, before they can get treatment, even though you're ready to go. You're ready with your lead, but I understand that there are many barriers. So could you tell us the top one or two barriers that causes a delay even after everything is now diagnosed and ready to go?
Yeah, the one important barrier is the time taken in the investigations, and usually there's a emergency neurology emergency in our hospital. So the patient died of a stroke directly goes to the emergency hospital. But yes, sometimes because it is a government hospital and the machines are too busy, so sometimes we have to wait for the investigation, particularly CT and CT angio. Our main workforce is CT and CT angio. But sometimes yes, we have to require MRI, and for MRI patient has to wait for a long time. And the another problem is the lack of availability of anesthesia, because sometimes most of the patients, I would say 30-40% are very restless, and we don't have the facility of anesthesia, and sometimes we have to struggle. So the lack of anesthetic people, and we sometimes wait a lot of time in the investigation. So these are the two main barrier in our setup that I would tell.
Yeah, so other barriers are giving consent, because the patient some want 100% outcome. That is one thing. Second thing is the cost. I think these are the two barriers in private setup.
Right. And in terms of, go ahead, Dr. Shah, if you have any additional comments on the barriers.
Sir, secondly, radiology also, like cost, again, patient going to the CT MRI, again, there is a barrier of getting the imaging done faster. So we don't wait for the reports. We ourselves only just see the scans and immediately shift to the cath lab. But the barriers are from the casualty to the radiology also. That is also one barrier. Because after the scans, we have to explain to the relatives. So after again, finances and then shifting to cath lab. So this takes lots of time, sir. Within 60 minutes, it becomes difficult, sir, sometimes to achieve that.
And let me just add a comment that the reason we are all talking about saving minutes is because every minute 2 million neurons in the brain die. Every minute that the blood flow is not restored. And this is translated, shown by scientific evidence in patients' chances of recovery with thrombectomy decreasing with the delay in taking the patient to the thrombectomy procedure and getting the blood flow restored. So just in the last 10 minutes or so, if one were to think about 2 or 3 of these barriers, Dr. Srivastav, certification of stroke centers in the US and other countries, each and every country where there is certification, has shown that it can overcome the kind of system barriers in the hospital that you're talking about, where the administration is now informed by a certification party, accreditation body, that all this stuff is required for you to be a stroke thrombectomy center. And so you cannot have a delay in imaging, in CT MRI, you cannot have a delay in anesthesia. And so what is your feeling about pursuing certification, strokes certification that now India has at your center? Would you want to pursue it?
Yeah, definitely, because this stroke accreditation is very, very important, and it should be spread to the public and as well as administrator, that this stroke ready and particularly mechanical thrombectomy facilities are available in these hospital in our city or in the state. So I think that is very, very important, and I think our secretary and presidents are working hard, and whole ICA team is working hard to get the accreditation centers to the stroke, and I think that is very, very important. And I think this should be bring to the notice to the administrator as well as to the public, that which are stroke ready hospitals. It should be displayed, I think, in the whole cities, so they know that yes, they should come to this hospital directly rather than wasting time here and there. Yeah.
I see that Dr. Sharma, who's spearheading the certification effort, has a comment. Please, Dr. Sharma.
No, I really thank for the discussion which is at present going on for Mission Thrombectomy, and what Dr. Tilochan has said. I'll just complete that. Definitely, the accreditation program, the way we started from last July 2022, and as we are doing more and more advanced accreditation, that is helping us to locate where the thrombectomies are done automatically. But we are looking more for the primary stroke center, as just like those who are attached with these thrombectomy centers, to increase more and more thrombectomies to happen and patient reach in time for the large vessel occlusion. So I think that is the indirect way of having a hub and spoke model, where the advanced stroke center which are accredited can have the 5 spoke as a primary stroke centers. And we are definitely looking forward to more than 100 centers to be done until next year. Thank you.
No, that's really great. So I have the next question for Dr. Hudev. Vikram, what's your thought on improving the payment situation? In other words, how can we overcome this barrier of delay because patient has to pay out of pocket? Should there be some outreach to private insurers, to the government insurers, so that patients don't have to think about paying out of pocket in such an emergency situation?
Yeah, Dilip, a main issue in India is the majority of patients, they don't buy health insurance. So I think if now after COVID, the numbers of health insurance, even in private, it is going up, but it is not significant. So majority of even software engineers, they buy the health insurance for 2 lakh. I think that's why unless that number increases, or we'll have some top up for neurointervention procedure. Like there are many top up insurances for cancer and everything. So these things we need to push more because if private numbers have to improve, this is the only way it will improve and help many people. Government for below poverty line and all government schemes are there, which can help many people in the government setup. I think overall, if number has to grow, it has to be both by government insurance and the private numbers also has to go.
I agree. I think for our audience, Ayushman Bharat has increased the reimbursement significantly for thrombectomy, but the number of hospitals in India that are adopting Ayushman Bharat is still quite low. And there is also some variability in the actual payment and the speed of payment state to state. And this is something that, again, ISA could take up because certainly the social determinants for stroke include poverty. And so risk factors are not well controlled in lower income patients, and they are very prone to stroke. And they really can benefit significantly from thrombectomy by avoiding a loss of productivity and certainly avoiding lifelong disability. I have a question. The next one is about using a standardized consent procedure. And I know that this is something that we haven't discussed before, so it'll be really interesting to see your thoughts. But because it's so complex to discuss thrombectomy with patients at 2 a.m. in the morning or their relatives, there have been efforts to create like laminated charts that have pictures and can illustrate. For example, the graph, I mean the pictorial. There is actually a technical name for it, where I showed that only 13 people improve with thrombolysis and almost 54 improve with thrombectomy. Those have been shown in small studies to be very effective in communicating to patients, especially in an emergency situation. Can you guys comment from your experiences if standardizing some of these consenting with some laminated sheets that ISA could produce and distribute, do you think those could help in explaining to patients quickly for consent?
Yeah, I think it is very good idea because our most of the peoples are illiterate. They come from the village and they don't understand any status. 15% versus 75%. So I think the pictures are very easy to interpret, very easy to understand, and I think your idea is very good. Rather, I will try within few days to have these pictures in my emergencies, so the consent can be easily understand by the patient attendant. Otherwise, they are most of the time confused with the percentage. So if they see the pictures, I think it's very helpful and particularly helpful for India and our countries where people don't understand too much about the things. So they understand picture better rather than understanding your statics. So the very good idea.
Right. And they can obviously be in Hindi or the state language,
Yeah.
In simple terms.
Yeah, I think that's good idea.
Dr. Shah?
Sir, even a video is also okay. In a early morning hours, if we get a patient to make them understand and show how thrombectomy works also, even pictures plus a video, a small video of a minute or two will definitely help, sir. I think we should try, sir. It's a very good initiative.
Awesome. So we are almost at the at the top of the hour. We are at 7 p.m. India time, and we have a minute or two for any other comments or questions, maybe from Dr. Surya or Dr. Pradeep Kumar, comments, thoughts, Dr. Sharma, and then we'll close.
Thank you, Dilip. I think it is a wonderful perspective what you have given. What I have understood is that the predominant challenge is patient not coming in time in India. Second is time taken for the consent and getting the imaging done. And third is cost, as Vikram has mentioned, and giving the consent. There are some hiccups like anesthetics, and I understand sometimes they are particularly in the night happen in some of the hospital that anesthetics is not ready to come. So these are real challenge. I think they need to be overcome, and our team should work on that. I feel that what we really need to do is all of the people who are doing the thrombectomy, they need to have motivate their patient to give a successful stories. I think these successful stories are much more impactful to the another patient and their relative rather than be convincing because they feel that the cost is something which is so much so doctor is pushing hard. But if these successful stories are played in some of the hospitals, some of the videos are placed, I think they will be more convincing to the patient and their relatives than we convince them for this. So these are my thought which I put up.
I will just add one point to what our president has mentioned. We can have, on behalf of ISA, we can send a letter to all the state governments and health ministries to initiate the process of stroke center accreditation and standardization of stroke care and implement, at least in all medical colleges, mechanical thrombectomy, and at the level of district hospital, IV thrombectomy. These things, I think, from our association, you can send draft letter and send, and everybody will be, most of them, this help being a concurrent list, state government can fund and take the policy at large. So I think that would be a good initiative. And I'm sure that our with dynamic president, Dr. Surya, and Secretary Dr. Arvind will definitely take this forward. And I thank Dr. Dilip Devagal for this wonderful presentation on the perspective of mechanical thrombectomy. The panelists also, Dr. Sripal, Dr. Gautam, sir, and as well as Dr. Vikram, for their participation and their interaction. And I think Dr. Arvind, because Arvind Sharma, Secretary of the Indian Stroke Association, he's continuous secretary for the last 3 years, maybe it's 4th year, and for the concluding remarks.
Thank you, our past president, Dr. Vijay Pradeep Kumar, for sharing this session, and really honor the way it has progressed from last 3 years, which I'm seeing with all my presidents. And I think I will congratulate Dr. Nirmal Surya on a short notice. We have gone to this program, and it's really thankful to our esteemed speaker, Dr. Dilip Yavagal, for agreeing for this, even attending the conference at European Stroke Organization. And I thank all the esteemed panelists, who Dr. Shripal, Dr. Trilochan, and Dr. Vikram Hude, who's part of our Indian Stroke Association. And really thankful to all the EC members and the participants who has come and dedicated their time here. So we are short of time, but definitely I will ask Dilip to, in a very short, there is one question in the Q&A. Before I close, any information on the gravity stent retriever cost benefit? If you can answer in a very short, otherwise I'll ask him to email you, right?
Yeah, so just 30 seconds. Gravity stent retriever is a new stent retriever that's being launched by a company called Gravity. The name of the stent retriever, the catheter is called the Neutron catheter, and the stent retriever is called Supernova. The main goal of the company and the founders is to bring low-cost stent retrievers and catheters to low and middle income countries. And for this, we are conducting the grassroots study that I'm the global principal investigator for. And this is, I think, a game changer, because the cost, once we complete the study and show clear safety and efficacy that is as good and perhaps even better than the existing stent retrievers, the cost of the device is going to be a lot less and much more affordable. And so I think it has a tremendous potential, and it's a very exciting development for India and other developing countries.
Thank you, Dilip. And that was a great question, I think, and it will be game changer for India. And I thank our President-elect, Dr. Vijay, also to be there on the panelist and all the EC members. And we close this session now. And it was a wonderful session. Thank you, Dr. Dilip, and all our esteemed panelists, and our President, Dr. Nirmal Surya.
And we have a photo.
Yeah, photo before we leave. If everyone can switch on the mic. Switch on the camera. I'm sorry. I'm extremely sorry. So everyone can switch on the mic. Usha, can you take the photograph?
Yes, sir.
Muthu.
Thank you.
Thank you.
So it is done. Thank you.
Thank you, everybody. Thanks for this.
Thank you, sir.
Dilip. Thank you, Dilip. Bye-bye. Have a nice conference.
Thank you. Thank you, everyone. Bye-bye.
Good night. Good night.
Bye-bye. Thank you.